So what we're going to look at now are ranges of motion of the foot and ankle. You will be experts in the foot and ankle. The one thing that you will always need to know is what are normal ranges of the foot and ankle. We ascertain what the normal ranges are so that, number one, if there's any limitation, we can flag that up. Number two, if we're wanting to make devices and inserts for the patient, we need to ensure that the ranges of motion are there so that we can adjust the foot. For example, if you will supinate the foot excessively and yet there's no motion at the subtalar joint, you will cause further problems in the distal aspect of the foot or even the knee. So you have to be careful and know what ranges of motion you have. So let's look at normal ranges of motion. So we'll start with the ankle joint, and the ankle joint functions in the sagittal plane. Yeah, so that is the main area that we look at. When we're looking at ranges of motion, in chair, we should be able to obtain 10 degrees of ankle joint dorsiflexion. What we do is we palpate the talar heads, we ensure that we're in a talar congruent position, we dorsiflex the foot, and once we dorsiflex the foot, we look at the lateral border alongside the fibula. And what we need is a right angle, which we have here. From what I can see there's a nice right angle, but with passive only, not active, passive, I should be able to gain an extra 10 degrees, and that's quite difficult. So there is a slight limitation there, but if I ask the patient then to actively pull back, it increases a little more. Okay, but we do need 10 degrees. So that is normal for ankle joint dorsiflexion. For ankle joint plantarflexion, we're looking at, again, we've got this. If we take that as the main point, if I place a finger there and we're going down, we should look at around 40 degrees of plantarflexion. And that appears to me to be normal. Why do we look at these ranges of motion? What we need to check is we need to check symmetry of motion, i.e. that they are the same on both feet. We need to look at quality. Does it feel smooth? Is there any crepitus? Is it easy to move the joint in that plane? Can you hear any sounds? We're also looking at the range, which is 10 degrees to 40 degrees. And the last thing that we're looking at is the direction of motion, to make sure that it is 10 degrees dorsiflexion and 40 and not the other way around. So that's what we need. The next joint that we're looking at is a subtalar joint. And the subtalar joint is made up of the calcaneus and the talus. Yeah. So what we're looking at is range of motion. What is normal? We check this in the frontal plane. So we are looking at a 2-to-1 ratio. So it should be 20 degrees of inversion and 10 degrees of eversion. So if you grasp just the back of the calcaneus and you invert and you evert, and that's about normal. It's very small. It's a lot less than you think. And that for the subtalar joint is normal. Once again, you look at symmetry to make sure both sides are the same. So you want to check that there is no difference between the two sides. Quality of motion, direction of motion, and range of motion. The next one is the mid-tarsal joint. And the mid-tarsal joint is made up of the calcaneo-cuboid and the talo-navicular joint. Okay, it comes across and that forms a mid-tarsal joint. What you want to do is isolate the subtalar joint by holding the back of the calcaneus, place your hand across the anterior ankle, and what we do is we supinate, bring back to the center, and then we pronate. The amount of motion that should be available here is 20 degrees of supination and 20 degrees of pronation, which is normal. It should not be in excess and it should not be less than that. Once again, as with all the other ranges of motion, you need to make sure that there is symmetry of motion, quality of motion, the direction of motion is equal and in the correct direction, and also range of motion. So it is 20 degrees each way. First MTP joint. Yep. So it's made out of the metatarsal and the phalanx, and what we need to check is the range of motion in the sagittal plane. So we are looking at 65 degrees of dorsiflexion. So you're looking at the metatarsal shaft versus the phalanx. So check, and then what you do not want to do is to hyperextend at the IP joint. You want to dorsiflex from the MTP joint. So we place the whole of the thumb along the whole shaft of the phalanx, and then you dorsiflex. And this angle here should be 65 degrees. Yep, that is dorsiflexion, and plantarflexion should equate to 100 degrees. And we can see here that there's a limitation. That should be 35 degrees, so it equals 100 degrees. And I'm getting about, if we look at straight here, I'm getting about 5 to 10 degrees. So that is limited. Okay. Once again, you check quality, symmetry with the other toe. You want to check that it is 65, so the range of motion and the direction. You want to make sure it's not going off in other directions, just in the sagittal plane. Right, as a summary, what I need you to know is which bones make up which joints. Yeah, that is vital. Often the ankle joint gets confused with the subtalar joint, and the ankle joint is the talus articulating with the tibia and the fibula, and the subtalar joint is the calcaneus and the talus. Again, the mid-tarsal joint, there is confusion and often gets confused with the other tarsal bones. It is a calcaneocuboid and the talonavicular, and the first MTP joint is the phalanx and the metatarsal shaft. You need to know not only the joints and which bones make up those joints, but also the figures and the numbers, which we deem to be normal. Only then will you know if there's a limitation of motion or if their motion is in excess. Yep. So please make sure you isolate the joint correctly. So not to have, for example, the subtalar joint and then the whole foot turning in an inverted position, because this way you are not only assessing the subtalar joint but the mid-tarsal and also the Lisfranc's joint. So all the joints will be included by doing this. Make sure you isolate and you use just the joint that you are testing. Why do we gauge the ranges of motion with feel? There are a number of tests that have been done, and that's how we've worked out what normal is, using instruments in terms of measuring. So a goniometer was often used, and still is, for training, in terms of calculating approximately what angles are there. The reason why we don't use this now routinely is because of the inter-observer error. So each time you do this, you'll get a slightly different range of motion, and between two intra-observer error, you'll find that it's even more inaccurate. And that's why we try to shy away from measuring equipment, because of the inaccuracy. However, as a learning tool, and if you're not too familiar with the angles, it's always a good starting point. So you can use this by placing it against the joint. So we place the point center across there, so it's at 0, and then as we dorsiflex, we move this in line with the hallux, and we can check to see how much motion we have. And we can see approximately we've got about 48 degrees. So, make sure both are in the correct plane of motion. So that one's just moved. Let's move that across, and we're roughly getting 70. Yeah, so more than enough motion. But as I've just made a mistake by holding that down, you've got to make sure that they're both in the correct plane of motion.
Okay, so measurement of joints can be done in slightly different methods, but as long as you can demonstrate that you are isolating that individual joint and measuring a range of motion, that is acceptable. So what we're going to look at is we're going to look at the first metatarsophalangeal joint, which is where the first metatarsal meets the first phalanx, and we're going to be looking at dorsiflexion range of motion and plantarflexion range of motion, giving us a total range of motion. In clinical problems, usually a restriction in dorsiflexion is the thing that gives us the trouble, and the minimum dorsiflexion that is required to be able to function normally is 65 degrees. Here we're looking at the first metatarsal, and what we're hoping is that we can do sort of a bisection of the metatarsal obviously without x-ray. It's impossible to be perfect. But here we can see the base, here we can see the head, and what we're looking at is making an appreciation of between the head and the base as to where that line will come. And luckily the pen's started to work, so that's good. So obviously the first metatarsal is going to be slightly plantar flexed. It's not going to be horizontal to the ground at any point. And this really is where things can slightly go wrong in terms of determining. The drawing of these lines is probably the thing that is the most unreliable, really. Here we've got the phalanx. So we're imagining a bisection of the phalanx. If you imagine where that bone is. And with any joint that you're assessing, you want to make sure the joints either side are immobilized. So it's just that joint that we want to assess. So here we're looking at flexion, which should be about 20 degrees. And here we're looking at extension, which in this case is about 90 degrees. Minimum of 65 degrees is required for normal gait, but most people will have quite a bit more than that. So if we're going to imagine the axis of this joint is going through like this, the axis traveling through the toe is obviously in two planes. It's obviously in the transverse and the frontal plane, and the movement of the joint is sagittal plane. With this joint, it is possible to have some transverse plane motion as well, but there is very little frontal plane motion in this joint. We do get a little bit of transverse plane motion, and obviously we've got an abductor and adductor muscle, which will be involved in that movement. But generally speaking, when we're assessing the range of motion, we're predominantly interested in sagittal plane extension and sagittal plane flexion. The next joint we're going to look at is the mid-tarsal joint, which is sitting at this point. The axis of the joint is actually at 52 degrees and 57 degrees inclination angle, so it comes across at about this kind of an angle. This is the oblique mid-tarsal joint axis. With all joints that you're assessing, this is actually a compound joint, so we've actually got the calcaneocuboid joint and the talonavicular joint together, which form this functional mid-tarsal joint axis. In order to assess this joint, we have to immobilize all the other joints. So we need to keep the subtalar joint still and the ankle joint still. So the way we do this is we actually grasp the rear foot, holding the subtalar joint and the ankle joint stable. And what we're going to be doing is we're going to be looking at this range of motion. We should have the same amount of abduction and adduction as dorsiflexion and plantarflexion, roughly, because the axis is 57 and 52 degrees to the relative planes. So this is a normal range of motion, and we can either have high degrees of motion or restricted motion. And generally, I explain to students to do this a lot to your colleagues and friends, and find out what a normal range is, and then you'll know what a restricted or an increased range of motion will be. Here we're going to be looking at the subtalar joint, which is this joint here, which sits underneath the talus and above the calcaneus. It's one of the more interesting joints. It actually connects the leg to the foot, and it translates transverse plane motion in the tibia into frontal plane motion in the foot. The axis of the joint actually heads upwards and forwards. So if you imagine a knitting needle going through the foot and coming out, it would head in that kind of direction. It's 45 degrees from the transverse plane, and it's actually 16 degrees this way, offset from the sagittal plane. So this will be a normal subtalar joint axis. So in terms of assessment, all we can really see is frontal plane motion, which is essentially the inversion and the eversion components of this joint moving. So what we need to do is we'll put it in neutral first of all, just to see where that sits. And then what we should find is that when we supinate, we get about 20 degrees inversion. And that's neutral again. And then when we pronate, we get 10 degrees eversion. It's always 2 to 1, and a normal range is 20 degrees inversion and 10 degrees eversion, with a total excursion range of 30 degrees. In excessive motion, you have more than that, and in restricted motion, you have less than that. It is possible to examine this joint in a supine position, but obviously I find that it's easier to visualize it in a prone position because you can effectively see the calcaneus much more effectively. Obviously, things happen in front of this joint, so you are trying to isolate the subtalar joint and not bring in any other joints into this assessment. Okay, what we're going to look at now is the talocrural joint, or the true ankle joint. Some people talk about the ankle joint and the subtalar joint being the ankle joint complex, but if we're testing the true ankle joint, we must keep the subtalar joint in neutral because subtalar joint gives us some dorsiflexion and plantarflexion as well. So we're going to keep that joint in neutral while we're assessing this range of motion. What I am looking for is this part of the foot. Now this is the hardest bit of this assessment, putting this line on. Even if the pen's working, it's still hard to get it in the right range. Don't forget, anything in front of this line here, you are now bringing in the mid-tarsal joint. So you can get some what we call pseudo-equinus, where the forefoot is plantarflexed on the rear foot. So we're interested in this position, and what we're doing is we're keeping the foot in neutral for this assessment, because as you can see, as I pronate the foot, we get dorsiflexion, and as I supinate the foot, we get plantarflexion. But we're just testing the ankle joint here. What we're imagining, if we could as well, is we're imagining a bisection of the leg, essentially the position of the fibula here, to give us that reference point. And what we're going to do is we're going to now put the foot in neutral. So we've got talar head congruency, feeling the talar heads here, and then we're going to push to resistance, and what we're expecting to get is 10 degrees dorsiflexion in this range of motion. This is the key thing. Anything less than 10 degrees, the patient won't be able to walk normally. They'll have to use some subtalar joint pronation to get that dorsiflexion. So that's why we've got to take this out. Now, plantarflexion, you can examine this range of motion as well, which is looking to see how much you get. It's about 35 degrees plantarflexion. In actual fact, it's very rare to get any restriction in plantarflexion unless you've got some disease of this joint, or unless you've maybe had some surgery. So the total range of motion is going to be somewhere in the region of about 45 degrees, with 10 of that range being dorsiflexion. The test that you've just seen with the knee fully extended, this is one of the benefits of doing it in a prone position. The patient can't flex the leg when they're sitting. If you get a little bit of flexion on the leg, it changes the assessment range. If you're sitting with the patient prone, you know that the knee is fully extended. This puts into play gastrocnemius, which inserts above the knee. And what we're going to do, the reason why I prefer to do this test prone is that you can test dorsiflexion with the knee extended, and then you can flex the knee. And as you can see, we instantly get another 10 degrees dorsiflexion with the knee flexed because now gastrocnemius is off stretch. If you don't get an improvement with the knee flexed, then you're looking at what we call a soleal equinus. And certainly I am concerned that maybe there might be some neurological spasticity if you don't get an improvement with this test, and I'll be looking at more neurological findings. The other thing that's very worthwhile mentioning is the end range of motion. What you're expecting is for the end range to be spongy like this. We've got a spongy end range. This would indicate what we call a soft tissue equinus. If you get an abrupt end range and it feels like hitting a solid block, then that is what we call a bony equinus, which is much more unusual, usually following maybe surgical procedures or maybe patients who have something like a talipes equinovarus or a serious bony restriction.